The risk factors of heart disease are quite varied, and some of those will be risk factors that are part of connected to your lifestyle, to other medical history considerations, and some will be factors which you don't have that much control about. So, for example, increasing age, propensity, if male sex, some ethnicity backgrounds, for example, from South Asian origin. Obviously, if you've got a family history of heart trouble, you can't change the genes you inherit from your parents, so those will be factors. But reassuringly, there are some risk factors for heart trouble that you can have some influence on. So these may be things like having a high blood cholesterol that your family doctor can check for, high blood pressure, smoking, obviously a very big risk factor, diabetes, and then some more general lifestyle factors such as lack of physical activity, being overweight with a high BMI. So they're quite varied. I generally tend to group risk factors into those that are non-modifiable and ones which are modifiable. So you can obviously target them if you're trying to adapt an approach to reduce someone's cardiac risk over the course of years to come. Well, you assess the risk of heart disease by coming to see a healthcare professional, your family doctor, for example, and they will go through those risk factors and make assessments of how you're responding to these issues. For example, what is your smoking history, getting your blood pressure checked, having a metabolic blood test to check your cholesterol measurements and your blood glucose, to screen for diabetes, for example, if you're not known to have it, and checking whether your diabetes is controlled if you have got it. In the UK at the moment, patients should be advised to go and see their family doctor. I think it's once every 5 years from the age 40 onwards. And that should involve having an assessment of your cardiac risk. We can put all these risk factors into risk scoring systems that will generate a lifetime risk score, a 10-year risk score, for example, of cardiovascular disease, and we can use those scores for individual patients to try and offer targeted measures to help bring their risks down. So so those are the assessments. You come and see a healthcare professional, they'll take a history, they'll go through the different risk factors and try and work out for you as an individual, where do you sit on the spectrum of these various risk factors. Well, chest pain, the first thing to say is that lots of people get chest pain from time to time, and for most people, chest pain will not be anything to do with the heart, and usually is nothing to worry about. I always like to think about what are the causes of chest pain by thinking of what is the anatomy inside the chest, and thinking of the things that can cause chest pain. So, for example, obviously, if you've been doing some exercise, or you bend down and you clearly feel you pulled a muscle, you might get some chest pain after that. So think of musculoskeletal causes of chest pain, muscle strains and sprains. There are other medical conditions that can affect the muscles, the bones, the musculoskeletal system in the chest. For example, rheumatological conditions like rheumatoid arthritis. There's a condition called fibromyalgia, which can cause chest discomfort around the muscles in the chest and around the shoulder region. Think of things like infection. So if you've got a chest infection, you can get some inflammation around the lining of the lung, something that we used to be called pleurisy, and that can cause a sort of sharp pain in the chest on breathing in and out. getting shingles on the skin or reactivation of the chickenpox virus can cause some chest discomfort as that's starting to develop. In the middle of the chest is the esophagus, obviously running down to the stomach below the diaphragm muscle, and people can get inflammation and acid reflux into the esophagus that can cause some discomfort, symptoms that you might think of like heartburn and sort of feeling acid reflux coming up into the stomach. Of course, we then think of the heart, and yes, of course, things like angina, heart attacks will cause chest pain, and those are the things that we obviously would assess if you were coming to see a healthcare professional to try and distinguish these different forms of chest discomfort. They often have different characteristics of how they present, their timeline, the characteristics of the symptoms, and so it's often possible when a healthcare professional is taking the history from a patient to try and focus in on what the most likely cause of chest pain is from how the patient is describing those symptoms. For example, if I've just been to the gym yesterday and I felt a muscle strain when I tried to pick up some weights, and the last 24 hours, every time I sort of bend down, I get a pain at the same point, then I'm sure that's a muscle strain. Whereas if I'm going for a walk down the road and at a certain point I start to get a heavy pressure in the chest that then goes away again, you might be, and I've clearly not just been to the gym or something in the days before that, I might be more focusing on, could that be a discomfort coming from the heart? Well, the main symptoms of a heart attack are usually chest discomfort. That it's true to say that the symptoms of a heart attack can vary from person to person, and it's not always the sort of classical clutching pain in the chest that you see portrayed on the TV from time to time in medical dramas, for example. But I think the classical symptom of chest pain is a sudden onset of a tight, heavy pressure pain in the chest, the center to the left side, feeling like an elephant sitting on the chest, like someone's pulling a tight band around the chest, feeling like there's a heaviness on the chest. And those symptoms, the discomfort can sort of spread up the neck to the jaw. It can spread down the arm. It may be associated with breathlessness, feeling sweaty, feeling sick, and some of the characteristics that can help distinguish it from other sorts of chest discomfort, for example, are that it's just lasting continuously. For example, having a heart attack won't really be helped by sort of it won't be changed or helped by different movements or position. It will be there constantly, whereas things like some muscular pains and aches can sort of vary depending on how you position yourself, and you're taking big breaths in and out. The pain can vary. You have to be always, that's generally the most common way that the symptoms develop, but you have to be aware that occasionally heart attacks can present in a slightly less specific manner. For example, we know in patients with diabetes, because diabetes affects the nerves and the sensory nerves and how they work, patients don't always get the sort of classical chest pain when they're having a heart attack. It can be more related to symptoms of breathlessness, and I think the textbooks say as well that in women versus men, that sometimes the classical symptoms for a heart attack, that classical chest pain, is not as a clear, sensitive presenting symptom for chest pain. So yes, most people will have a severe chest pain, but we just have to be mindful that's not always the case. Well, as I said, I'll go back to what I said earlier, that I think for most people, chest pain probably won't be anything serious and nothing to worry about. But I think the reasons you need to seek medical attention if you've got chest pain. So, for example, if you have a sudden onset of chest pain that's making your chest feel tight and heavy, spreading up your arms through to your back, to your neck or your jaw, associated with those other symptoms we talked about, breathlessness, feeling sweaty, then I think you have to call 999 and you have to get yourself assessed by the emergency medical services. When things are occurring in more of a sort of a sort of lower intensity onset, for example, you've just noticed that you are getting a bit of chest discomfort from time to time that comes and goes, I think you should see your GP or any healthcare professional with expertise in this area. If you have some chest discomfort that comes and goes, is worse with exercise, generally if it doesn't settle very quickly and is clearly something that's unusual compared to your normal baseline of how you feel. And ultimately, as I said earlier, chest discomfort can present somewhat non-specifically. So I think at any point, if you're at all worried about getting intermittent discomfort in the chest, as I said, most people it may be a simple muscle strain, but it's best to get that checked out and tell a healthcare professional about the symptoms you're getting, and hopefully they'll be able to advise you. Well, I think what I would say about that is that as we've talked about the symptoms, I think the most important factor to help a healthcare professional diagnose whether there's any significant heart condition is actually the history the patient is telling you about their symptoms, the characteristics of those symptoms. That can be the most helpful factor to help target what specific investigations you're then going to follow on from. Once you've heard about the symptoms, hopefully a healthcare professional will conduct a physical examination and listen to the heart and lungs and do some various checks of the sort of for muscle strains and rheumatological conditions that those things can be checked for. Leading on to sort of specific investigations, well, a 12-lead electrocardiogram and ECG will obviously give some information about how the heart's working, and the pattern of the ECG can help diagnose particular conditions that can affect the heart, like angina, obviously in the acute setting, heart attacks. If it is an acute onset chest pain and you're being assessed as a sort of urgent emergency scenario, then there are some cardiac biomarker blood tests that are elevated if the heart is acutely under stress. A protein that comes from the heart muscle cells called troponin can be checked in the blood, and if that's elevated, it tells us that the heart is under stress at that point in time. So that can be a helpful distinguishing factor acutely whether someone's having a heart attack, for example. On a wider setting, we may be remembering again about the anatomy of other structures that are in the chest, like the lungs, the esophagus, and the musculoskeletal system. So things like a chest X-ray, having a CT scan of the chest to exclude blood clots in the lungs and look for evidence of infection in the lungs. Thinking of heart arteries and sort of angina, heart attack causes of chest pain, then yes, we may go on to do more in-depth tests of the coronary arteries, like a CT coronary angiogram or an invasive coronary angiogram to image the arteries and see if there's any blockages in them. Sometimes an ultrasound scan around the heart called an echocardiogram can look for inflammation around the heart. It can check your heart valves and the function of the heart muscle. So those things are important. And in addition, because there are varying causes of chest discomfort, and trying to make an assessment of what the most likely cause of that chest discomfort is, often as part of those more targeted investigations, we may also do some tests which are really sort of trying to work out your cardiac risk. So, you know, I may check someone's cholesterol, I might check their blood glucose, we'll check their blood pressure. Those parameters in themselves don't diagnose the heart condition as a cause of chest pain specifically, but alongside those more targeted tests, if you've got some tests that tell me someone's cholesterol's high, someone's got poorly controlled diabetes, then that helps me integrate those numbers into someone's cardiac risk to give me an idea of the likelihood that someone may be having more serious chest pain coming from the heart, for example. So there's a wide range of different diagnostic tests we can do alongside the clinical assessment, which we use to try and help target what the most likely cause of the chest pain is ultimately to come up with a diagnosis.